So I would like to thank the organizing committee of this webinar for inviting me for this lecture. So I'm an interventional radiologist, and I'm doing both vascular, endovascular treatment for brain vascular malformation and spinal vascular malformation. And also I'm doing spine percutaneous intervention for metastatic disease or fracture. So today we will focus on new percutaneous treatment for spine intervention. 6 months ago, I presented to you our experience with vertebroplasty and cementoplasty, and today we will try to go deeper in more complicated procedure and in ablation therapy. So this is my disclosures. So this is the plan of this presentation. So we will focus first on advanced and challenging vertebroplasty cementoplasties. I will discuss about screw fixation of C2 lesion. We will speak about transoral vertebroplasty for lesion involving the occipital condyle. I will talk about the safe technique for complex vertebral fracture and or vanishing vertebra due to osteolytic metastasis. We will speak about the complex management of aggressive hemangioma, and I will focus just on challenges, how to overcome the challenges for the needle positioning and how to overcome the challenges to remove soft tissue leakage when we have a leakage of cement around the bone lesion. Second, we will focus on ablative technique, radiofrequency ablation, mainly, and cryotherapy. And thirdly, we will speak about electrochemotherapy, which is a new technique to treat metastasis with an extension to the epidural compartment. So first, a focus on advanced and challenging vertebroplasty and cementoplasties. So we in the previous webinar, we have spoken about the cementoplasty of the cervical spine. So we have a technique which is very reliable to inject the cement in the cervical spine lesion. But you have to keep in mind that the PMMA bone cement has a good resistance to compression constraint, but a poor resistance for torsion and flexion constraint. And when you deal with C2 lesion, especially on the odontoid process, you have some flexion constraints on this area. So here you have a patient that we treated by the regular technique we use. So this is an osteoclitic lesion of C2 involving the odontoid process and the body of C2. You can see it on T2 weighted MRI. Okay, so we did the anterolateral approach under general anesthesia. You see the bone needle, 11 gauge bone needle inside the lesion, and just a cement injection. And what happened a couple of weeks after this intervention? Yes, the patient experienced a deficit. It was not a severe deficit, but it was a mild motor deficit on the upper limb. And you see that there is a fracture just below the cast of cement. So probably in this C2 osteolytic lesion, the cement is not enough because you have some flexion constraint, and not only, like for the other vertebra, not only the compression constraint. That's why to avoid such a complication of a fracture below or through the cement cast, we try now to propose a percutaneous screw fixation of the C2 and odontoid process. So here an example, a 72-year-old female. She had multiple bone metastases from a breast cancer. So you can see numerous osteolytic lesions involving among other lesions, the spinal, the cervical spine. So you see this huge osteolytic lesion involving C2 and the base of the odontoid process. There are other lesions involving C3, C4. You can see the lesion on T2 weighted image. So this is a huge osteolytic lesion. You can see also the lesion on axial T2 weighted image. There is no obvious epidural extension, but the lesion is located mainly on the left side and in the body of the C2 vertebra. So this screw fixation, we can do them in our hybrid angio suite, combining a CT scan and a monoplan flat panel, so to have a good positioning of the screw. Or also we can do it on our biplane angio suite using the needle guidance technique. So this is the procedure. So the patient, of course, is under general anesthesia. The lesion was mainly located on the left side. So that's why we use the left anterolateral approach between the trachea and the cervical ICA. So you have to push laterally the ICA and put the needle between the trachea and the carotid, the left carotid. So this is a 11 gauge bone needle. So this is the trajectory. You see the very ascending trajectory of the bone needle. And you see that the goal of this screw fixation was not to put only the screw in the C2 because it was a vanishing lesion, I would say. We tried to put the screw from C3 to C2 toward the odontoid process. So you see the ascending trajectory of the bone needle. This is a cone beam CT acquisition to check the positioning of the bone needle, which is accurate. And afterward, because of the screw, we were afraid to damage the nerve, the surrounding nerves or the surrounding vessels. So we performed an hydrodissection. So this is a 22 gauge needle through which we inject some saline with contrast material. So about 150 cc of saline in order to push the vessels and the nerve and to avoid damaging them while positioning the screw. So here you see the hydrodissection. So you see we inject some saline with contrast material to see the distribution of this hydrodissection. And here we put a Kirchner needle to have the trajectory of the screw, and through this Kirchner spindle we will put the screw here, okay, with a corkscrew, and push the screw toward the C2 lesion. And afterwards, so the screw is in its position. The diameter of the screw is 6.5 millimeter and the length is 5 centimeter. And afterwards, we put a needle close, a bone needle close to the screw and inject some cement to reinforce the setup. So this is the result at the end of the procedure. And you can see the satisfactory screw fixation with cement of the C2 lesion. And this patient, we performed this treatment more than 1 year ago, and she didn't experience any fracture or displacement of the screw. So it could be a way to overcome the risk of fracture through the cement cast or below the cement cast if you do only a regular cementoplasty. Other challenge to treat cervical lesions, the lesion involving the occipital condyle, so the C0 lesion vertebroplasty. So here it's a 69-year-old male who had a cavum cancer, and he had a recurrence involving the right occipital condyle. So you can see this recurrence, which is here. Okay, so you are losing. There is an infiltration of the normal fat of the bone. Okay, and here you can see on T2 the lesion which involves the right condyle. And you can see on CT the osteolytic lesion involving the right occipital condyle, which is here. So in such a lesion, the best route to treat this lesion and to put a needle in this lesion is to use a transoral access. So of course it's under general anesthesia. We collaborate with our ENT team to put a mousse gag in order to expose the posterior aspect of the pharynx. And we will use so we will perform a CBCT acquisition, cone beam CT acquisition. And on this acquisition, we will use the needle guidance, which will help to delineate the target to put the tip of the needle in the occipital condyle. So you can see here the positioning of the bone needle inside the occipital condyle. This lesion was close to the course of the vertebral artery, the right vertebral artery. So we also navigated a balloon in the right vertebral artery through the radial access and inflated the balloon during the injection of cement. And this is the cast of cement after injection in the lesion involving the right occipital condyle. And you can see on the CT scan, you have a good feeling, I would say, of the lesion with the bone cement. And the patient had a very significant improvement of his pain. He had a proton therapy on this lesion also, but the cementoplasty helped to decrease the pain, the symptomatic pain. What about severe osteoporotic fracture or huge osteolytic lesion? So let's talk about a technique which has been developed by our colleague from Italy, Professor Cianfoni, which is called the SAFE technique. It's the stent screw assisted internal fixation. So what are the indications of this technique? It could be either a severe osteoporotic fracture with a crush deformity or pedicle fracture associated with the vertebral body fracture. And we could also use this technique for vanishing osteolytic vertebral body lesion. So when you have a lesion which destroys almost all the vertebral body, it could be a good option to use this technique instead of the regular vertebroplasty. So the principle of this technique is to put a cannula in the pedicle, and through this cannula we will put stent which are mounted on balloon in the vertebral body, and then we will put screws through the pedicles towards the stent, and finally we will inject some bone cement to complete the setup. So this technique has been published a couple of years ago in the JNIS by your colleague, Professor Cianfoni. So this is a picture showing you the principle of this technique. So first you put some cannula in the pedicle. Through this cannula, you will deploy a stent mounted on a balloon. And afterward, through the pedicle, you will put some screw, one screw in each pedicle. And finally, you will inject some cement to finalize this setup. So an example in an 80-year-old male who has a porotic L2 and L3 fracture. And so you can see these two fractures which are fresh fractures, painful. And you can see on the most lateral sagittal reconstruction that there is a fracture of both left and right pedicles of the L3 vertebra. Here you have the MRI, so you see on T2 it's a fresh fractures, and as I told you, there is a fracture of both the right and the left pedicle of the L3 vertebra. So here is the technique. So we will put some cannula in the pedicle, okay? So under general anesthesia, of course, through a posterior route. And through this cannula, we will deploy a stent mounted on balloons. So this is the VBS small size, 15 by 13 millimeter stent. Afterward, we will put some screw via a transpedicular approach. Okay, so you will see the positioning of the screw through a transpedicular approach. So the diameter of the screw is, as for the cervical screw fixation, it's 6.5 millimeter of diameter and 5 centimeter of length. And so this is the positioning in lateral and epi projection. Okay, so the screw is put inside the lumen of the stent, and afterward we will put a bone needle in L2 and in the vertebral body of L3, and we will inject some cement to have a perfect consolidation of both L2 and L3. And this is the CT scan after the procedure. So you will avoid some delayed fractures through the cement cast if you use this technique on complex osteoporotic vertebral compression fracture. On the last webinar, we talk about vertebral hemangioma. So you know that vertebral hemangioma are very frequent, but usually they are asymptomatic. The percentage of symptomatic vertebral hemangioma is around 1% of the cases, mostly the aggressive hemangioma with extension to the perivertebral space and to the epidural space or the posterior arch. And you have different modality to treat this vertebral hemangioma. anesthesia, surgery, radiotherapy, which is not really used frequently, and percutaneous technique. So I showed you that we published a case series in 2016 in the European Journal of Radiology about our technique of treatment of patients with an hemangioma with an extension to the epidural, the anterior epidural space. So first we do a DSA to locate the Adamkiewicz artery. Then, under general anesthesia on prone position, we will put a bone needle in the posterior aspect of the vertebral body, and we do a phlebography to see where the alcohol will go, and we afterward inject some pure alcohol in the epidural, the anterior epidural component, and 2 weeks after we do a vertebroplasty of the vertebral body, and this prior sclerosis with alcohol prevent the migration of the cement in the anterior epidural space. So let's see a complex case of aggressive hemangioma of the T2 vertebra. So it's a 67-year-old female. She presented with pain in the upper thoracic spine, irradiating in both upper limb with paresthesia. So you can see on CT the typical aspect of vertebral hemangioma. And on T1 and contrast enhanced T1 image, you can see the extension to the perivertebral area and also in the anterior epidural space. Okay, so the patient was painful, she was symptomatic, so it's an aggressive hemangioma. You also see the extension to the posterior arch. So we decided to do our technique, which consists in doing first a sclerosis with pure alcohol of the epidural component, and 2 to 3 weeks after to do the regular vertebroplasty through a posterior approach. So this is the positioning of the needle to perform the sclerosis with the alcohol. So you see the positioning at the posterior, the posterior 1/3 of the vertebral body. And to see where the alcohol will go, we always do a phlebography through the bone needle and see what happens. So we are injecting through the bone needle contrast material, and you see some vessels which are going in this big vessel and with another vessel going upward. So we open the field of view. And what is this vessel? This is the subclavian artery. So here you have a retrograde filling when you inject through the vertebral body through the hemangioma contrast material. You have a reflux in the arteries, the branches from the supreme intercostal artery, which is connected to the costocervical trunk. Here you see the deep cervical artery, and I'll remind you that the deep cervical artery usually give rise to a radiculomedullary artery feeding the anterior spinal artery, and here you pacify the right subclavian artery. So here, if you inject the alcohol, you will have alcohol which will go everywhere in the subclavian artery, so you will kill the patient or have a very, very, very severe complication. And it was the same on the left side. Okay, you can see retrograde filling of the intercostal artery, the first and second intercostal artery on the left side. So I remind you the anatomy of the upper thoracic metameres. So you have a balance between the supreme intercostal artery, and the superior intercostal artery. The supreme intercostal artery is arising from the costocervical trunk, from which is arising the deep cervical artery, and the superior intercostal artery arises from the origin of the descending aorta and will feed the upper intercostal metamer. So there is a balance between the supreme and the superior intercostal artery. And here, this is the same patient. So we did a DSA from the left subclavian artery, and you can see the vertebral artery with the feeders from the V2 segment supplying the entire spinal artery, but also from the deep cervical artery, you see this radiculomedullary artery feeding the anterior spinal artery. So here, it was a contraindication to inject the alcohol like this. So what did we do? This is the ultra-selective injection through the radiculomedullary artery feeding the anterior spinal artery coming from the deep cervical artery. So what did we do? We navigated a microcatheter in the supreme intercostal artery, and we occluded all these vessels which were feeding the hemangioma. We occluded this vessel with coils and with liquid embolic agent, with EVOH, and we did the same on the right side. So we devascularized the T2 vertebral body to avoid the reflux while injected the alcohol through the bone needle. And so we reperform once more the the sclerosis with alcohol a second time, and here you have the bone needle in place, and when you do the phlebography, you don't see anymore the reflux in the supreme intercostal artery because we occluded all these vessels by intra-arterial route. You see only veins, epidural veins, which are here. So here you can do the sclerosis. This is the same on the left side. So you can do the sclerosis with alcohol. So we inject alcohol diluted with contrast material, 3 cc in each from each side, and afterwards, 2 weeks after, we perform the vertebroplasty to fill the vertebral body. So this is the result at the end of the procedure, and you can see the satisfactory filling of the T2 vertebral body with no complication. We performed this case. It was 5 or 6 years ago, and the patient is okay. So another challenge was that we have to overcome when we are doing a challenging cementoplasty or vertebroplasty is the positioning of the bone needle. So usually we use our hybrid angiosuite combining a CT and a monoplan flat panel. We can use the biplane angiosuite and perform a cone beam CT acquisition and use the needle guidance tool. But we also have this tool. It's a French startup which is called Imactis, and they develop an electromagnetic navigation system to enhance the precision of the accuracy of the positioning of the bone needle for a percutaneous intervention. So here you have to put on the patient, to fix on the patient a referential which contains fiducials and an emitter which will generate the magnetic field. And so this is the positioning of this small box on the patient. So you have to put it it should not move during the procedure. Otherwise, you will lose all the landmark and you won't be able to position accurately your bone needle. Afterwards, you perform a CT scan with this tool, which is fixed on the patient. And afterward, we will transmit the image to the workstation, and the software will automatically detect on the image the fiducial of the patient referential. And afterward, we will position the needle care, which will be connected to the needle, which will be clipped to the needle, and which contains the electromagnetic receptor in the electromagnetic field. Okay, so this receptor should not be too far from the electromagnetic field, so less than 25 centimeters. And afterwards, the fiducial are linked between the emitter position on the image and its position in the real life. And finally, the CT volume will be registered on the patient, and the software with the screen will display you 2 orthogonal slices passing through the bone needle. So so just to show you the positioning of the emitter of the electromagnetic field, then we perform the CT acquisition, and afterward you will have a screen like this, and with this device which is clipped on the bone needle, you will see the trajectory on your CT scan. You will see the course, the theoretical course on the CT scan of your bone needle. So you have a trajectory which will be put on the CT scan to see where your needle will go. So we perform a preliminary study involving 12 consecutive patients using this technique, mostly reinforced cementoplasty and cementoplasty on the sacrum and pelvic bone. This is the patient demographic, so mainly a patient with a bone lesion tumor. And here an example, a 81-year-old patient with the gastric cancer. He has this S1 painful metastasis, and sometimes it's not so easy to put a needle in this lesion because you have the nerve roots, the S1 nerve roots in the first sacral foramen, which are closed. You have to avoid, of course, the sacral canal. So it's not always easy to put a needle in this lesion. So here you can see when you put the device on the proximal aspect of your bone needle, you can see the trajectory, the theoretical trajectory of your bone needle. So you can, and it's in real time, so you can inclinate and change the positioning. It will show you the trajectory of your bone needle in two orthogonal planes. And afterwards, you can see when you repeat the CT acquisition, you can see the advancement of your bone needle. So you can have a satisfactory and very accurate positioning of your bone needle and be able to fill the lesion without any leakage, especially in the sacral foramina. Another example, a 65-year-old male with a S1 metastasis from an unknown primary cancer. And you see the same, it's challenging to put a bone needle. Usually we use a transsacroiliac approach, but here the trajectory is not always easy to find accurately. So here you can see using this electromagnetic field device, you can have a very precise transsacroiliac route. Here you have the first sacral foramina, which are here, and this is the result after the injection of the bone cement. So you don't have any leakage in the sacral foramina and also in the sacral canal, and you have here the CT scan after the injection of bone cement. A last example of this 80-year-old patient with a porotic fracture of the sacrum, so it's a H-shaped fracture, and here the goal will be to perform a reinforced cementoplasty, so using spindles through the transsacroiliac approach in S1 body and S2 body. So through the sacral alae, we will put a spindle here and another one here, and afterward we will inject some bone cement to have a satisfactory setup. So this is the positioning of the emitter on the patient, and here you can see in live, we connect the device to the proximal aspect of the needle, and you can inclinate the trajectory of your needle to see what is the best trajectory to avoid here the foramina, the sacral foramina, in which you have the S1 roots. So you can see this is the second trajectory in the S2 body, and the positioning of both spindles, and here's the result at the end of the procedure. So you have one transsacroiliac spindle which will consolidate the S1 body, and another one is the S2 body, and we inject some cement to have a very solid setup and to avoid delayed fracture and to obtain pain relief. Once more, it's very important to have a satisfactory positioning of the referential, because if you have if it's moving, you will lose all the landmark and you will have a false and not accurate positioning of the bone needle. So here you see it's not well apposed and it will migrate. And here it's a first acquisition, and during the second acquisition of the CT, it moved. So here you will lose everything, and your positioning will not be accurate. So you have to fix it very tightly to avoid any migration of this of the emitter. And just a few words about the results of our preliminary experience. So it helps to reduce the scopy time. So it reduces the time of the procedure, and also it reduces the X-ray dose delivered to the patient, and we had no major complication using this technique. Second challenge, sometimes, as I told you in the previous webinar, we can have some soft tissue leakage when you inject the cement, and also we can have some mispositioning of spindle when we do reinforced cementoplasty. So we have some tip and tricks to remove this leakage or this malposition of spindle. So I will just talk about it briefly. So Cement leakage in the soft tissue is not so rare. It could be as frequent as in almost 8% of the cases, and they may be responsible for postoperative pain. It's like a needle inside the soft tissue, so it could be painful. And the risk factor for this soft tissue leakage is the course of the bone needle through towards the lesion, and when you have a cortical bone disruption. And sometimes when you don't inject all the cement which is in the dead space, you will release some cement while you remove the bone needle from the vertebral body. So here you have some example of what we could have as soft tissue leakage. So you have all this soft tissue leakage in the soft tissue surrounding the vertebral body, which has been treated by vertebroplasty. So tips tricks to remove this leakage. So sometimes you are lucky enough to have the cement leakage which is visible at the skin, so you can remove it just manually. But sometimes you see you have you have a leakage which is partly in the pedicle, but also in the muscle, in the paravertebral muscle. So what you could use, you can use a supple biopsy forceps. So this is the bone needle, and through the bone needle, you try to grab the proximal aspect of the cement leakage. So it's almost like at the fun fair, you try to grab, the toy with this, and sometimes you can remove this fragment. Okay, so it's almost like at the fun fair. It doesn't work always, but it could be helpful to avoid the pain, the postoperative pain due to this leakage in the soft tissue. And here you see you can remove this spindle, this leakage of cement in the soft tissue. Another example of migration of leakage of bone cement during a vertebroplasty, it was left C1 metastasis from a lung cancer. So you can see the osteolytic lesion of the lateral mass, left lateral mass of C1. Here, coronal reconstruction. As I showed you previously, we use a transoral route to reach this lesion. So this is a bone needle which is positioned toward the lesion. This is the final positioning of the bone needle. We always use a protective balloon in the vertebral artery to avoid any migration of the cement in the vertebral artery. This is a cone beam CT acquisition to be sure that we have an accurate positioning of the bone needle. And after the injection of the bone cement, we had this fragment which migrated in the uvula. So we wanted to remove it to avoid the pain. So we used a supple biopsy forceps. And here, I'm sorry, the movie doesn't work, but we were able to remove this fragment from the uvula. So this is the final cement cast in the C1 left lateral mass. We don't see anymore the fragment in the uvula, and this fragment was removed using the supple biopsy forceps. Another example, a patient who presented a S1 fracture. It was a patient who underwent a lumbar fixation for degenerative disc disease. So we perform this cementoplasty of the S1 vertebral body, and this is the positioning of the needle, and we add this migration, this release of cement in the soft tissue. So the patient experienced pain after a couple of days after the intervention. And here, using the needle holder, it's very easy through a very short incision to remove this soft tissue leakage. And final example, another tip and tricks, here is to repositionate a spindle in a patient treated by reinforced cementoplasty. So it was a 72-year-old female. She presented a sacral fracture related to a trauma, and she had a surgical fixation, but she has still pain. So you see, this is a previous surgical fixation. She had a screw here, but it has been removed because there was an infection. And you see that the fracture is not healed. So there is an absence of healing of this fracture. That's why the patient is still painful. You can see here there is an absence of consolidation of this fracture. So we decided to perform a reinforced cementoplasty. As I showed you in the previous webinar, we put it some spindle in the fracture, and afterward we inject some cement to consolidate this setup. And what you could see, this is the first spindle, which is here, and the second one, she was malpositioned in the sacral canal. So you cannot leave the spindle in this position. So what we performed, we cannulated with the bone needle this spindle, and using the supple biopsy forceps, we will try to grab the proximal aspect of this spindle, and we will be able to pull it and put it in a satisfactory position. I will show you. So we grab the proximal aspect and we remove the tip of this spindle, which was inside the sacral canal. And this is the final result. So we just performed cementoplasty on the right side, in which we add this screw from the previous fixation. And here you have the reinforced cementoplasty with the spindle and the cement. Another challenge is the pelvic bone and sacral lesions. So I showed you in the previous webinar that we perform usually regular cementoplasty, but sometimes it's not enough to stabilize the fracture or to obtain pain relief. So as I showed you, we use a regular cementoplasty, or we use reinforced cementoplasty with spindle and bone cement, but once more, it's not always enough to obtain pain relief. That's why nowadays, more and more, we use percutaneous through fixation, especially for complex fracture. So here, this patient had a right sacral ala fracture. So what we perform is a screw fixation under general anesthesia. We use a 7-gauge bone needle, and we do an exchange with a Kirchner spindle. And afterwards, as for the cervical screw fixation that I showed you, we position this screw through the transsacroiliac approach to obtain a consolidation of the fracture. And here you have another bone needle to inject some cement and to consolidate this screw fixation. So you can see here the two screws with the transsacroiliac roots. We use the electromagnetic guidance tool that I showed you, the IMACTIS electromagnetic guidance, to have a very accurate positioning of the screw, and it helped to treat very easily this fracture. Another example of a complex lesion of the pelvic bone, a 70-year-old patient with breast cancer, multiple pathological fracture of the pelvic bone. You can see here the lesion involving the vertebral body of S1, the left ala of the sacrum. Also, the iliac bone is involved by another metastasis, and here you can see the transsacroiliac screw fixation with an additional cement injection, and here another screw fixation through the iliac bone to consolidate this fracture. And at 3 weeks, the patient was able to walk without assistance, and at 6 weeks, there was no residual pain. She also had radiotherapy, but she had no residual pain. So this was the first chapter on the complex vertebroplasty and cementoplasty. And now we'll talk about the ablation therapy technique. So it's mainly dedicated for metastasis of the spine and of the pelvic bone and sacrum. So the goal is to first obtain pain relief, because usually these lesions are painful, and also to have a local tumor control to avoid the spread of this metastasis and the progression of the metastasis. So you can cure this lesion either by heat using radiofrequency ablation or microwave, or by cold using cryoablation technique. So we will talk about these two techniques. What are the indications for ablation techniques? So we don't use them for all the metastases. We use them when you have a unique metastasis, so you want to have you want to be carcinologic and to cure the patient. When you have several metastases, but one is bigger than the other, so we will focus on this biggest lesion using ablation technique. And also when you have an extension from the vertebral body towards the surrounding soft tissue to destroy this extension to the soft tissue. So once more, we don't use ablative technique for all the patient, only in this indication. So RF ablation, so it will use radiofrequency waves. Which are non-ionizing electromagnetic radiation. The frequency of this wave range from 400 to 500 kilohertz, and the aim of this radiofrequency wave is to have a thermic, so it will increase the temperature, thermic destruction of the tumor lesion without causing injury to the surrounding tissue, especially of the spinal cord. And so the goal, the target of the temperature is more than 55 degrees Celsius to obtain cell death, but we don't want to reach a temperature over 100 degrees Celsius, because otherwise you will have a carbonization of the surrounding tissue, which will damage the surrounding tissue. So once more, when you use this radiofrequency ablation, we will have a production of heat by friction in the tissue by these waves, which will lead to coagulation necrosis, so destruction of the cell without promoting carbonization. And afterwards, after this radiofrequency ablation, we will have fibrous tissue, which will take place at the treated site. So once more, the target temperature of the radiofrequency ablation is between 55 degrees Celsius and 100 degrees Celsius. If it's less, you won't have any destruction of the tumor cell. If it's above 100 degrees Celsius, you will have carbonization, and the effect it will be poor. So the indication of the radiofrequency ablation is mostly painful bone metastasis. You can use also it for osteoid osteoma. Contraindication is the same as for vertebroplasty when you have a local infectious process, because you have a risk to put bacteria inside the vertebral body. And when the lesion is too close to the nerve root or the spinal canal, because you have a risk to have a thermal injury of either the nerve root or the spinal cord. So this is the device. So you use the cool tip device, but you have numerous device to do this radiofrequency ablation. So this is the probe that we will use, which will be inserted in the lesion to treat. You have a cutaneous panel to have the negative probe to have the current. And everything is connected to the radiofrequency generator. We perform this radiofrequency ablation under general anesthesia because it could be painful. You can perform this procedure under CT or fluoroscopic guidance. So we position a bone needle inside the lesion. Afterwards, we will position the RF probe in a coaxial fashion, pull back the bone needle to avoid the contact between the bone needle and the active part of the radiofrequency ablation probe. And afterward, you connect the probe to the RF generator, and you start the radiofrequency ablation. So this is a drawing summarizing the different steps of the procedure: positioning of the bone needle in the lesion, then the positioning of the RF probe. You pull a little bit the bone needle to avoid the contact between the active part of the probe and the bone needle, to avoid the retrograde heating of the skin. And afterward, you will connect to the RF generator. So this is a real case. So this is the cutaneous panel, the positioning of the bone needle, and through the bone needle, we will position the RF probe inside the lesion. It's a mixed lesion from a breast cancer, so it's a mixed metastasis of the iliac bone, and you see the positioning of the probe, and afterwards we will perform the RF ablation. Another lesion involving the proximal aspect of the right femur, so you can see the positioning of the needle, and afterwards through the needle we position the RF probe. We pull a little bit back the needle, and afterward we will perform the RF ablation, and afterwards the cementoplasty to have consolidation, and here you can see a small venous leakage. Another example, it was a mixed lesion involving the right aspect of the vertebral body. So through a transpedicular approach, we position the bone needle. Then through the bone needle, the probe, we pull a little bit back the bone needle to avoid the contact between the active part of the probe and the bone needle. And we perform the RF ablation, and afterward injection of cement to have a consolidation of the lesion. And this is the result, the CT scan. So you see it was a mixed lesion with this component which was osteoblastic. And in the literature, you have a very good efficacy in terms of pain relief. So you have pain relief in more than 60% of the cases. You have also a reduction after radiofrequency ablation of analgesic use, ranging from 50% to 100% of the cases. And the rate of local recurrence is varying depending on the studies. So here you have an overview of the main first studies performed with radiofrequency ablation on a bone metastatic lesion. And this is our early experience using this technique, which we published a couple of years ago with very satisfactory results. So in this case series, we perform 30 RF procedure in 24 patients with various metastatic lesions from various neoplasm. We treated mainly pelvic bone lesion and spine lesion in this patient, and you see here's the decrease of the score on the visual analog scale. So it was before the procedure and after the procedure. So you have a very good effectiveness in terms of pain relief, and also it helps to reduce the use of painkiller, and also the functional outcome is very good because 74% of the patients were able to walk after this procedure. And also in bearing zone lesion, I think you have to use to add cementoplasty, because the radiofrequency ablation won't consolidate the bone lesion. So if you do only a radiofrequency ablation, you have a risk of secondary fracture. So usually in this bearing zone lesion, we use additional cementoplasty. But when you compare radiofrequency ablation alone and radiofrequency plus cementoplasty, the additional cementoplasty doesn't bring a higher effectiveness in terms of pain relief. Complication in the literature, you can have skin burn if you are too close to the skin, and also which is which is the most frightening for us is it is a nerve root or spinal cord thermic lesion. So the spinal cord is very sensitive to thermic injury. If the temperature is above 45 degrees Celsius, you can have a definitive thermic lesion of the spinal cord, and you can have this thermic lesion of the spinal cord even if the posterior wall of the vertebra is preserved. So it doesn't prevent to spinal cord thermal injury. So you have to be very careful, and usually we use a security margin of 10 millimeter, 1 centimeter, to be sure that we won't have a thermal spinal cord injury. And as I told you, if you do only radiofrequency ablation without cementoplasty in bearing zone lesion, you may have a secondary fracture, so you have to do additional cementoplasty to prevent this. And here, this is from our case series. We had two severe skin burn lesion in lesion which were very close to the skin. So here you see it was a lesion of the iliac wing, which was very close to the skin, less than 1 centimeter, and we had this skin burn lesion. And in our case series, we had one case of lesion of the spinal cord. So it was a patient treated. She had multiple metastases from breast cancer. One was a prevalent metastasis at a T10 level. So this is vertebroplasty at T9, T11, and T10. We perform radiofrequency ablation, and you see probably the lesion was too close to the spinal cord. We didn't respect the 1 centimeter margin, and you have this thermal injury of the antero left lateral aspect of the spinal cord, and the patient had some deficit of the left lower limb. Another example of a patient using another device for radiofrequency ablation. So the patient had an oral cavity cancer and a unique metastasis of T11. This is a metastasis. So we wanted to cure completely this metastasis because it was the only bone and a soft metastasis. So we decided to do radiofrequency ablation plus cementoplasty. We used a different device, not the cool tip, but the radiofrequency setup from Merit, the STAR device. It has a probe that could be curved at the tip in order to enhance to have a more spread radiofrequency ablation zone. So you can see you can curve the tip of this probe. So this is the positioning of the probe inside the lesion. We perform the radiofrequency ablation and secondarily the vertebroplasty, and we had very good outcome with no recurrence using both RF ablation and vertebroplasty. Second, ablative therapy that we can use in bone metastasis, the cryotherapy. So the cryotherapy will require one or more needle to be positioned in the metastasis under usually CT guidance. So usually it's not only one probe, but 2, 3, 4, depending on the size of the lesion. And the principle of this technique is based on the Joule-Thomson effect. So when you have a rapid decompression of argon gas at the end of the probe of the needle, you will reach a temperature which is of minus 180 degrees Celsius in a few seconds. So here you have an example from an article from our colleague from Gustave Roussy Hospital, Frédéric Deschamps, published in 2014. You see this lesion, which, as I told you, this is a good indication because you have an extension to the paravertebral soft tissue. So here you have positioning under CT guidance of different probes, and you can see, which is very convenient, you can see the ice ball under CT, which is generated by the cryoablation. So you can monitor during the procedure, the ablative procedure, you can monitor the size of your ablation using the CT guidance. You see this hypo-intense oval shape image, which corresponds to the ice ball generated by the cryoablation. So here an example of a 51-year-old patient with a medullary cancer of the thyroid. The patient had multiple metastases and one painful metastasis of the left scapula. So you can see this osteolytic metastasis with an extension to the muscle, to the surrounding muscle. So here's the osteolytic lesion. So under general anesthesia, we put 4 probes of cryotherapy inside the lesion under CT guidance. You can see here the positioning of these probes under CT guidance. And afterwards, we did the cryoablation. So you can see when you are doing CT acquisition, you can see in live, you can see the ice ball, which is generated by the cryoablation, and you can control the extension of your ablative therapy. And here we used a glove with hot water to avoid a skin burn lesion, because this lesion was very close to the skin. And this is so the final ice ball we had with a complete destruction of the lesion. And afterwards, we injected some cement in the bone part, the lytic bone part of the lesion to reinforce this scapula. And this is the result at the end of the procedure on CT scan. And finally, we have some cases with vertebral lesion with extension to the epidural space. And when you perform vertebroplasty in this configuration, you have a risk of leakage of the PMMA bone cement in the epidural compartment, which could lead to spinal cord compression or nerve roots compression. So usually, when you have a huge epidural extension, it's a contraindication to regular vertebroplasty. In this configuration, it's also a risky situation for ablation therapy. And usually, what we do is radiotherapy and decompressive surgery. But in some cases, the epidural component is radioresistant. So the radiotherapy is not efficient on this epidural extension. So what to do? And we are using, since recently, a new tool which is called the electrochemotherapy. So these tools will perform reversible electroporation. So it will open the membrane of the cell, helping the chemotherapy to enter inside the metastatic cells and to enhance the effect of the chemotherapy. So in this technique, we use the bleomycin. So this is the technique. So we do a reversible electroporation using this technique. So there is a current which will go from one probe to another and which will help to open the membrane cell. And while after injection of the chemotherapy, when you do this reversible electroporation, it will help the chemotherapy to enter in the cell and to enhance the effectiveness of the bleomycin. So here it's images from the first case series published by your colleague from Gustave Roussy in 2023. So you can see positioning of the probe either in a paravertebral location or in a transpedicular position. So you see it was a metastasis with a huge epidural component. And this is the result. A couple of months after the electrochemotherapy, you see that you have a complete disappearance of this epidural extension. So we just did a couple of cases in my department. I will show you one of the first cases we did, a 67-year-old patient who had a metastatic prostate cancer and this osteoblastic lesion of L5 with an epidural extension. The patient has no motor deficit, neither motor nor sensitive deficit. So you see the huge epidural extension very close to the coda equina. The nerve roots. You see, it's an osteoblastic lesion, so osteoblastic lesion with a huge epidural extension, which was not sensitive to the radiotherapy. So here, this is the positioning of the needle to perform the electroporation. So we put it 6 needles above and below the lesion to treat, and through a transpedicular approach. So this is the positioning of the needle, and you will generate a current going from one needle to another to open the membrane cell. So you have to perform this procedure under general anesthesia because it's very painful for the patient. You cannot do it under consolidation or local anesthesia. And here you have the 3 months MRI follow-up. So you see, you have a complete disappearance of the epidural component that was present before the procedure. And you see complete disappearance of this epidural extension. So this is the result from the early experience from our colleague from Gustave Roussy Hospital. They treated 40 patients with metastasis with epidural extension, which was resistant to radiotherapy. So they had a response, which means a complete response or partial response in about 2/3 of the cases. Clinical benefit in terms of pain relief and neurological symptoms, but you have to be aware that you can have some severe complications using this technique, and they experience 3 cases cases of postoperative paraplegia. So it's a useful technique, but this is the beginning of the use of this technique, and maybe we have to improve this technique to reduce the risk of severe complication like paraplegia. So the take-home messages of this presentation. So for challenging cementoplasty, vertebroplasty, there is a benefit of using additional screw fixation. It's very easy to do now with the tools we have, CT guidance, convenient CT guidance, or a dedicated electromagnetic tool to enhance the accuracy of the guidance. I showed you some tips and tricks to remove soft tissue leakage or malpositioned spindles. Ablative technique, you have mainly radiofrequency ablation and cryotherapy. So as I told you, the main indication is unique or prevalent lesion or when the metastatic lesion has an extension to the perivertebral soft tissue. And there is, in my opinion, a huge potential for electrochemotherapy with a reversible electroporation for metastases with epidural extension that are not sensitive to the radiotherapy. And just before concluding, I would like to advertise the second masterclass of neurovascular anatomy that we will organize in April 2025, the 10th and 11th of April 2025. So it could be in person or in Zoom. And in this event, we will talk about the spinal cord vascular supply, and you will see some fancy images like this one of the embryology of the arterial supply of the spinal cord from the lab in which one member of my team is working, Dr. Emma Chotar. So you have the QR code for the registration. So it will be the 10th and 11th of April 2025 in my institution in Paris, in Pitié-Salpêtrière Hospital. And I would like to thank you for your kind attention. If you have any question, I would be pleased to answer them.
Thank you, Professor, for your wonderful lecture. And before going questions, as a moderator, I want to ask one question. What is the maximum number of vertebra do you perform vertebroplasty to avoid some complication?
There is no real rule, but usually when you are treated a lot of level at the same time, you increase the risk of cement migration, especially venous cement leakage. And also we had 2 or 3 cases of patients who had cardiac arrest, maybe due to the too high amount of cement. So I think there is a dose limit, and our colleague from orthopedy knows that you cannot inject a huge amount of cement, and it could have like a systemic effect. So usually we treat 5 to 6 level at the same time, especially in patients with osteoporotic fracture. You know, you have a lot of fracture and no more than 5 or 6 vertebrae at the same time. So we do 2 procedures. If there is, I don't know, 10 lesions, we do 2 different procedures.
Thank you, sir. I want to ask about from your cases, which is T2 hemangioma. You're occluding the pillars, vascular pillars, and you're doing phlebography. And if some of the veins, you cannot stop the vascular supply. What will you do? What do you prefer to treat?
I think we cannot inject the alcohol if you have, you know, intralesional shunt with reflux in the arterial feeder, because here at the first time, if I had injected the alcohol, I would have alcohol migration in both the subclavian artery, which would have been catastrophic. Yeah. Maybe I won't be here to talk with you. I will be in jail because it will be a huge complication. So that's why we have to do this phlebography, because sometimes you don't have the intralesional shunts and reflux in the arterial feeders, but when you have it, you can avoid complications. So that's why we do this phlebography systematically. And usually you can occlude the feeder through the arterial access. Otherwise, we would have discussed with the surgeon to maybe do surgical treatment of this lesion. But I think we cannot inject alcohol if you have a risk of reflux in the subclavian artery. It's too risky. You cannot control the migration of the alcohol, and it's very toxic, and you can have very severe complication. You can kill the patient, I think.
Yeah, thank you. And we are going questions and contributions. Professor Hasan Kamil Sucu says, really extreme and very demonstrating cases. Thank you for sharing. It says,
Welcome.
Efecan, Professor Said asked many questions, and he gave a lecture about the spinal metastasis with cyberknife in İzmir Online Neurosurgery meetings more than 3 years ago. Maybe he want to ask himself by himself because there are many questions from him. If he is available, maybe you want to ask.
yeah.
Professor.
Just before the question, I can comment all the cases I presented to you are discussed through a multidisciplinary meeting. So with a surgeon, orthopedic surgeon, and oncologist and radiotherapy. So we never perform the percutaneous treatment without discussing all these cases, because usually it's a strategy combining surgery, percutaneous treatment. So it's a multidisciplinary decision.
Yes, thank you, sir.
Professor Said Şirin, you can turn on your microphone.
Okay. Hello, everybody. Thank you very much, Professor. I don't know, how do you pronounce your last name? Clarençon? Is it
Clarençon.
something like Portuguese?
No,
Is it Portuguese?
French.
No, but the letters are different than French.
It's French, but it's complicated to pronounce for non-French people. I agree.
Hello. So I have some questions, but I don't want to dominate the meeting. But I saw the first case, one of the first case, you first gave some alcohol and then vertebroplasty, right?
Yeah.
Actually, we couldn't see the reduction of epidural spinal cord compression after alcohol.
I agree. I didn't show the images. So the epidural component didn't disappear completely, but it was reduced, a little bit reduced, and the patient she still had a little bit of pain. I treated this patient, I don't know, it was 6 or 7 years ago. She has a little bit of pain, but she's better than before the treatment. So I don't have I didn't show you the MRI, the control MRI, but there is a small reduction of the epidural component. Not complete, I fully agree, but it was enough to have like a bearable pain for the patient.
So, and again, from the whole presentation, you do vertebroplasty plus thermoablation or cryoablation. You don't put any further radiation in any means, right? Radiosurgery or external beam radiotherapy. You just do, for example, RF plus vertebroplasty.
No
additional radiation.
For patients who are eligible for radiotherapy, we do both, because there is no contraindication to do radiotherapy after vertebroplasty. In patients who had radiotherapy, it's more complicated to do surgery after, because the wound healing could be complicating. You have a higher risk of infection. But for patients who had percutaneous treatment, you can do radiotherapy before or after it. There is no problem. So most of the patients I presented, I didn't mention it, but they have radiotherapy. So it's a combination of both techniques. So the pain relief could be related to both, I think, the vertebroplasty and radiofrequency ablation or cryotherapy and the radiotherapy. It's a combined effect, I think.
Yeah, I agree. I mean, since you didn't mention about additional...
I mentioned in a couple of cases, but not all of them. But in most cases,
I mean,
radiation
you
therapy.
shouldn't leave them alone, just being vertebroplasty and thermo or cryotherapy, right?
I fully agree. I fully agree.
So, how do you decide on doing vertebroplasty, especially for osteoblastic metastases?
So for osteoblastic,
Not lytic, but blastic ones.
Yeah. So they are less frequent compared to osteolytic lesion, to be honest. Usually they are not purely osteoblastic, they are mixed lesion with, osteolytic component and osteoblastic component. So usually what we do, if it's possible, if it's not too close to the spinal cord, we do radiofrequency ablation plus cementoplasty, but the filling of the lesion with the bone cement is very complicated because there is a poor filling of the lesion with the bone cement, but it's feasible. So usually we use this strategy for these osteoblastic lesions.
So, I mean, for example, for occipital condyle, do you think that it will cause an instability in the
No,
future?
I don't think so. For C1 lesion and occipital condyle, we only treated osteolytic lesion with a risk of fracture, which could lead to neurological compression.
Because of instability after fracture, the instability.
Pain and instability, both to have pain relief and to stabilize the condyle or the C1 metastasis.
Okay, I don't want to ask too many questions, but I really enjoyed. I did have many data from your presentation.
Thank you very much.
Actually, as they mentioned, I do radiosurgery, SPRT. How do you call it? I don't know. Maybe SABR, stereotactic ablative radiotherapy, for many cases for spinal mets. But again, I know that for some RF cases, they use MR monitorization to see the actual thermal effect of RF, and then you can stop it or you can go on. You can really see the tissue heat during the MR monitorization, and you do not do that, right?
No, we use it was what I presented was our early experience. Now what we use a thermocouple which we place in the epidural space to monitor the temperature, because you don't see the ablation you do as you can see with cryotherapy. In the cryotherapy you see the ice ball. In radiofrequency ablation you don't really see what you do, but we use a thermocouple, so a device that we put in the epidural space to monitor the temperature. And if the lesion is too close to the spinal cord or to the nerve root, we can do a hydro dissection of the epidural space, or we can inject some CO2 to avoid to move the spinal cord from the lesion and to insulate, I would say, the spinal cord and avoid thermal lesion.
But you do not see the whole, for example, axial cut, let's say, you don't see the all thermal effect in the prevertebral area, paravertebral area. You just monitor the epidural space.
But
right?
I know that some teams, but it's not really a regular practice. But you can use a MRI to monitor the temperature. But it's mostly for research purpose. It's not like regular basis clinical treatment. But you can do it. I agree.
Okay. Thank you. Thank you a lot.
Thank you for your questions.
Thank you for contributions, Professor Said.
Thank you. Thank you, sir. And Professor Kamil Sucu asks, what is the brand of the name of the RF probe you use for the bone metastasis?
You can use OsteoCool, which is dedicated to RF ablation of bone lesion, and we have also the RF ablation tool from Merit with the tips that you can curve and which will help to enhance the size of the ablation zone that you will perform.
Thanks, sir.
And the old one was the cool tip, which is not dedicated to bone. You can use it for, liver or other organs, the cool tip. And the osteocool is from Medtronic is dedicated to bone lesions.
Thank you. And Dr. İsmail Ertansevin from our clinic says, thank you very much for your presentation, full of cases. What is your approach to the cement leakage into the canal?
When you have cement leakage in the canal?
Yeah.
So the best way to manage complication is to avoid complication, I would say. So we try to avoid as much as we can this migration. To be honest, I have my experience. I started in 2009, so 15 years of experience. I didn't have any symptomatic leakage in the spinal canal. I had some leakage in the anterior epidural space, but luckily it was always not symptomatic. I think you have to respect the safety rule. If you have an anterior epidural component which is compressive or pre-compressive, you should not do the vertebroplasty. You should discuss with the surgeon before, do the posterior laminectomy and fixation to liberate the spinal cord, and a couple of weeks after we perform the cementoplasty of the vertebral body. And the other safety rule is to perform the vertebroplasty with a good quality angiosuite. So we have a monoplan flat panel with a high quality to see what you do, because if you have a poor quality fluoroscopic device, sometimes when we are going to the operating room in orthopedy, sometimes they have an old device. You don't see really the X-ray quality is poor, and you can have leakage that you don't see. So the key is to see what you do and to have good quality fluoroscopic guidance. And when we take the cement, if we have migration of the cement close to the posterior wall, we prefer to stop and to have not a perfect filling rather than taking the risk to have intracranial migration of bone cement. And if we have such a compressive bone cement migration in the spinal canal, we call the surgeon, orthopedic surgeon or neurosurgeon, to do a decompressive laminectomy. That's why we have good relationship between with the neurosurgeon and the orthopedic, because when you have a complication, you have to call your colleague and the reverse. So it's a teamwork.
Yeah. Thanks, sir. Dr. Ayhan Karat, you observed 3 paraplegia after procedure. What do you think about this patient? In our country, it is not easy to explain such a complication to relative of patients. What about France, he says?
So it was not our complication. It was in the first experience of our colleague in Gustave Roussy. It's the first experience with this device, which is not at the beginning dedicated to spine lesions. It was dedicated to liver lesion or kidney lesions. So I think there is like a learning curve, but I agree that when they presented this result, I was a little bit afraid of this significant risk of paraplegia, because we are treating this patient to avoid paraplegia. So if you create the paraplegia by the treatment, you lose your goal. So we just did a couple of cases. We did 3 or 4 cases, and we did very selected cases with a low risk of neurologic complications. So we didn't have such complication, but I agree that it's a concern, and we have to be sure that we are not more harmful than the disease itself. But I think it's a good there is a good potential of this technique, because as I showed you, the case we did, you have complete disappearance of the epidural extension, which is a big problem for some of these lesions, which are impossible to cure with other techniques.
Yeah, thank you. I couldn't say any contributions or questions. I want to ask one question, sir. Do you during the ablation, do you need a water hydrodissection?
It depends if it's close to the spinal cord or close to a nerve root. So if it's very close to the posterior wall, yes, we can do an hydrodissection of the anterior epidural space. So either a dissection using water with a contrast material to seize, or using a CO2 to have like an insulation and to protect the spinal cord.
Okay, thank you. Here in this meeting, dear Professor Bektaş Açıkgöz is here. I want to ask him about his contributions or questions.
I would like to congratulate Professor. Thank you again for sharing your experience with us. Thank you very much.
Thank you.
And Professor Kamil Sucu.
It was a wonderful lecture. I want to thank again
Thank you.
Professor Clarençon, or am I good to pronounce? I don't know. His second time in our conferences. Thank you so much.
My pleasure. It was a real pleasure. Thank you for the invitation again.
I want to thank everyone who joined us today, this evening. Thank you so much. Bye-bye.
See you soon.
See
Bye,
you.
thank you.
Good night.